Okay, good morning, everyone. Welcome to February Journal Club. We recognize that many Indigenous nations have long-standing relationships with the land upon which the University of Toronto's Department of Medicine is conducted. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississauga, the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis people, and we're grateful to have the opportunity to live, work, and gather on these territories. Land acknowledgements are only a starting point for larger conversations. More concrete acts of restitution, donations have been made to Indigenous women shelters from our Journal Club, and treaty reviews and transformation are needed to address underlying inequities and blatant discrimination in the distribution of resources between Canada's First Peoples and settlers. We have two exciting presentations this morning. Our first speaker, Dr. Victoria Chuen, past Esther and Saul Baker Award winner and Dr. Christopher Patterson Resident Research Grant recipient, to present to us an RCT for an anticipated novel route of administration of anti-Parkinsonian medication. Dr. Chuen, over to you.
Thanks so much, Dr. Gandel. Hi, everyone. So today I'm going to be presenting on a paper titled Safety and Efficacy of Continuous Subcutaneous Foslevodopa-Foscarbidopa, a randomized double-blind active control phase 3 trial. Of note, this drug is actually still under review by the FDA and Health Canada, but in speaking with a few neurologists on my recent movement disorder rotation, is quite hopeful and believed to gain approval in the coming years. So I hope that this is a helpful introduction to a new potential drug that we may start seeing more regularly in our Parkinson's disease patients and stimulate some initial discussion. I have no conflicts of interest to disclose. Our objectives for today are first to review the pathophysiology of Parkinson's disease and current treatment modalities that are available. I'll provide an overview of this paper and then our critical appraisal. So Parkinson's disease is a neurodegenerative disorder within the class of synucleinopathies. And amongst older adults over the age of 65 years old, it's the second most common neurodegenerative disorder. The neuropathological hallmark of Parkinson's disease involves neuronal loss within the substantia nigra, which then leads to striatal dopamine deficiency. Secondly, we also see intracellular inclusions containing aggregates of alpha-synuclein. The clinical presentation includes both motor and non-motor symptoms, and the treatment of Parkinson's disease is really focused on pharmacologic replacement of striatal dopamine. The mainstay of treatment of the motor symptoms in Parkinson's disease is with levodopa, which is always administered with a carboxylase inhibitor known as carbidopa. And this essentially prevents it from being converted into dopamine while it's still in the peripheral circulation. It allows it then to pass through the blood-brain barrier as levodopa, and then there it's converted into dopamine where it acts within the CNS. Other agents used in PD are often implemented to prevent the breakdown of dopamine itself, such as COMT inhibitors or MAO-B inhibitors. And you can also have direct dopamine agonists themselves, which can be used independently or concurrently with levodopa to act directly on the dopamine receptors. Now, the natural progression of Parkinson's disease is that over time, the therapeutic window of dopamine levels will become smaller and smaller, as depicted by the light blue areas here. Over time, you can see this window shrinks, and the patients end up with more frequent supratherapeutic or undertherapeutic levels, which can either result in dyskinesias in the on stages or off periods. In the advanced stages, patients may require more frequent dosing of levodopa to maintain levels in the therapeutic window. But unfortunately, they may also encounter more fluctuations, as you can see here. Currently, the two most common advanced therapies offered to patients experiencing motor fluctuations is either with deep brain stimulation, known as DBS, or duodopa. So DBS is a neurosurgical intervention where electrodes are inserted directly in the brain, allowing impulses from a pulse generator to be sent to target areas of the brain, which then help to control the motor symptoms. Patients with cognitive impairment, though, are usually not offered DBS, and other considerations for our patients include surgical complications and risk of infection, as well as the need for eventual replacement due to battery loss with a pulse generator. Duodopa is a gel formulation of levodopa and requires surgical insertion of a PEG tube, which then allows it to be directly delivered into the duodenum where it's absorbed. The caveat is that, of course, it also involves a surgical procedure for PEG tube insertion, and then the pump that has to be warm for the 16 hours for which they're receiving the infusion supposedly weighs about 3 pounds on its own. Other adverse events are typically related to the pump site itself with the PEG tube, or about 5 to 10% of patients will develop a generalized peripheral polyneuropathy as a result of duodopa therapy. And so, as you can appreciate, in older adults, DBS may not be considered if there's cognitive impairment, and duodopa may be avoided due to the requirement for surgical intervention for implementation. And I think this is why the introduction of a potential new subcutaneous form of levodopa, if it's approved by FDA and Health Canada, will be of interest to our patients. And so foslevodopa-foscarbidopa is a prodrug of the usual levodopa-carbidopa that we're familiar with. And essentially, that's what allows it to be 100 times more soluble than the oral form of the medication that we're familiar with. And that's what allows it to be delivered in a subcutaneous fashion. Now, moving on to our paper, which was published in December 2022 in Lancet Neurology. In terms of the study question in a PICO format, the population included patients with idiopathic Parkinson's disease aged 30 years and older who were on a minimum of 400 milligrams a day of levodopa equivalents with inadequately controlled motor fluctuations and average off time of at least 2.5 hours per day over a 3 consecutive day average. The intervention here was our continuous subcutaneous infusion of the foslevodopa-foscarbidopa, and the comparator was the oral immediate release tablets of levodopa-carbidopa. The primary outcome that they looked at was the change in the average daily on time spent without troublesome dyskinesias, where that was normalized to a typical waking day of 16 hours to account for differences in sleep patterns across participants. This was a randomized, double-blind, double dummy, meaning that everyone was given a pump to be worn, active control study. There was an initial screening period where they were able to recruit 145 patients to RCT. And then following that was something called the stabilization period, which lasted 2 to 3 weeks. During this time, they converted all the levodopa-containing medications and COMT inhibitors to the nearest whole tablets of levodopa-carbidopa IR tablets. And they used only whole tablets in order to maintain capsule blinding during the randomization period. All other agents were allowed to be continued, like dopamine agonists or MAOB inhibitors. And then in the last week of the stabilization period, no additional changes were made prior to randomization. Finally, there was 12 weeks of the double-blind treatment period, which I'll go into a bit further in the next slide. But of note, all participants had to attend a total of 13 visits throughout the entire study. This just depicts the randomization in the groups, which either included the intervention group here, where they received 24 hours per day continuous sub-Q infusion of foslevodopa-foscarbidopa and oral placebo tablets. And then in the control group, they received 24 hours per day continuous sub-Q saline infusion as the placebo, and then oral IR levodopa-carbidopa tablets. If receiving the intervention infusion, the continuous infusion rate was essentially calculated based on the dose determined at the end of the stabilization period using an algorithm that was previously developed based on the known pharmacokinetics of the drug from phase 1 studies. And during the initial 4-week optimization phase, they adjusted the infusion rate of the foslevodopa-foscarbidopa to maximize the functional on time, minimize the amount of time with troublesome dyskinesias, and minimize the number of off periods during the day. Afterwards was the maintenance phase lasting 8 weeks, where all drug regimens were not to be changed any further. However, dose adjustments of non-study drugs were allowed only if there was, a medical emergency that was deemed necessary by the investigators. Throughout the study, all participants were allowed an open-label IR levodopa-carbidopa tablets as rescues, and all participants were asked to maintain a Parkinson's disease diary to document what kind of state they were in on an every 30-minute basis. For example, being on the on state with dyskinesias or being in an off state. And so they had to record that every 30 minutes. The primary endpoint here was assessing the change in the mean daily normalized on time with troublesome dyskinesias. This analysis was done by means of a mixed model repeated measures to account for data collected at follow-up visits prior to the 12-week mark and accounted for patients who dropped out prematurely. They identified multiple secondary outcomes, which are listed here, including the change in off time, the change in ratings on the motor aspects of experiences of daily living scale, and presence of morning akinesia, amongst many others. To limit the type 1 error rate, meaning reporting falsely significant results, they applied a hierarchical order of analysis procedure. And really what this means is that the researchers ranked their hypotheses, all of their secondary outcomes, in a descending order of importance. And then as they completed their analyses in a serial manner with having set their p-value at less than 0.05, if an analysis down their hierarchical order demonstrated a p-value of non-significance, then all further tests down the ranked secondary outcomes could only be considered exploratory rather than being able to draw a formal conclusion about the outcomes in a statistical manner. Now, moving on to our results, beginning with the baseline characteristics. So most patients were white males, with males making up 70% of the total study participants, and 93% of all participants were white. The mean age of participants was 66.4 years old. And on average, most individuals had been diagnosed with Parkinson's disease about 8.5 years prior to the study. They did report baseline MMSE scores, which were quite high at 28.77, but unfortunately, they didn't report any other baseline cognitive impairment data or any other information about functional status or frailty. Based on the Parkinson's disease diary, there were some differences in terms of the baseline Parkinson's disease diary outcomes, such as the reported off times or on times with troublesome dyskinesias, as you can see. But it's important to note that the primary outcome they looked at was the average change from baseline rather than the absolute time spent during the day. Now, in terms of their primary outcome, looking at the amount of time spent in the on period without any troublesome dyskinesias. This was defined as a sum of on periods with both non-troublesome dyskinesias and on periods without any dyskinesias. The treatment group had experienced a significantly greater increase in time spent throughout the day being on and without troublesome dyskinesias. Now, looking at the secondary outcomes, similarly, the treatment group experienced a significantly greater reduction in time spent in an off state. However, when they looked at the MDS-UPDRS Part 2 score, which is essentially a survey looking at the impact of motor symptoms on activities of daily living, they found that there was no significant difference between the groups, so the authors did note that this was clinically significant. However, hierarchical testing for significance was terminated given that that component did not reach significance. And so given time limits for today, I'm not going to go through the remaining secondary outcomes that they tested for. Finally, just to note, the authors proposed that the increased time spent in the on period without troublesome dyskinesias was likely attributed to more time spent being on and without any dyskinesias, as you can see with the greater proportion of the green section here for those who were treated in the foslevodopa-foscarbidopa group. Now, in terms of adverse events, there was a higher proportion reported in the foslevodopa-foscarbidopa infusion group, and most were attributed to infusion site events, which affected 72% of individuals receiving the treatment drug. Of note, and I think of interest to our particular group, is the presence of hallucination or psychosis, which occurred in 15% of those in the treatment group, compared to only 3% in the control group. The authors note that these events were non-serious and no action was required to be taken with the study drug. I also wanted to point out that falls were more common in the control group, which could perhaps be explained by the improved control of motor symptoms and reduced on time with any dyskinesias. Lastly, interestingly, there was reported on and off phenomenon in the treatment group as an adverse event, but they didn't actually clearly define in the paper what this meant. And as we could see in the previous slide, both groups of patients had experienced both on and off periods. So that lacks a little bit of clarity. Now moving on to our critical appraisal, was the assignment of patients to treatment randomized? Yes, patients were randomly assigned using an interactive response technology system. Were the groups similar at the start of the trial? I think generally yes, but this also lacks a little bit of clarity in terms of the fact that there was no p-values that were reported to demonstrate any differences between the groups. And we did note some differences in terms of the initial Parkinson's disease diary reports. Were the groups treated equally? Generally, yes. So they applied the same restrictions in terms of drugs changes allowed, the use of rescue medications, number of visits mandated, and the duration of follow-up. However, I think one could argue that the treatment group was allotted a bit further finer control of their symptoms due to the initial 4-week period in the initial randomization phase, where they were adjusting the infusion rates to optimize the on periods with dyskinesias, minimizing the off periods. Though I think in reality, the benefit of such a therapy that they're looking at will allow you to completely personalize the infusion rates to target symptoms. For all patients who entered the trial accounted for and analyzed in the groups to which they were randomized, yes, an intention to treat analysis was performed by applying a mixed model for repeated measures analysis. And were measures objective? So no, they weren't. All measures were actually subjective in that they relied on patients to record their on and off periods using a diary, recording information every 30 minutes, which you can imagine can become very cumbersome. And then they also used the UPDRS scale in their secondary outcomes, which is also subjective in nature. Were the patients and clinicians kept blind to which treatment they were being received? Yes, so all study personnel and patients were masked to treatment allocations, and essentially you cannot tell the difference between the tablets that were administered from placebo, and all individuals were also wearing a pump. How large was the treatment effect? So I calculated the Cohen's d, which was 0.408, and we typically consider a score of 0.5 as having moderate effect size and 0.2 as a small effect size. And so this is trending a bit closer towards having a moderate effect size than no effect. And lastly, will the results help me in caring for my patients? So I think this patient population is representative of probably a group that's more cognitively intact, though we lack a little bit of more clarity in terms of the baseline cognitive diagnosis, as they only reported the MMSE scores. We also don't have information in terms of their frailty and functional status. And then I think the study did look at some relevant outcomes related to the time with bothersome dyskinesias, impact on functional status, and they captured relevant adverse events such as falls and hallucinations. I think ultimately, though, if approved, the use will really be based on shared decision-making to optimize favorable and patient-centered outcomes. And I think just to highlight some benefits, I think with the subcutaneous therapy, a major highlight is that it can be easily started and discontinued. And so if patients do experience adverse events or they find that they don't like it, the option to revert back to prior treatments is much easier than with, of course, duodopa or with CBS. And so I think that makes it much more appealing for patients and reduces the barrier to implementing something for advanced therapies. I think there's also the potential in the future to eliminate other Parkinsonian medications if it's able to sufficiently control motor symptoms on its own. And that could eliminate a fair degree of polypharmacy, which we know can be a major issue in controlling Parkinson's disease in the advanced stages. So the bottom line is that 24 hours per day continuous subcutaneous infusion of foslevodopa-foscarbidopa provided significantly more hours of on time without troublesome dyskinesias, which was likely driven by an increase in the amount of time without any dyskinesias. However, if FDA approved, phase 4 clinical trials will be helpful to inform us about longer-term side effects and tolerability beyond 12 weeks of use. Here are my references. Thanks so much, and I welcome any comments or questions.
Thank you so much, Victoria, for a beautiful presentation, clear, beautiful slides on a novel therapy that likely I don't know, but I've heard too that this is likely going to be approved. Go ahead, Gary, your hand is up.
Victoria, great presentation. Thanks very much. I just wanted to make a comment in the critical appraisal about the comparison of the groups and the comment that there were no p-values. Some of the statisticians that I work with have always said that the use of p-values for the table 1 in papers is a misuse, because p-values are a statistical test of hypotheses. And table 1 is not a hypothesis. So I would suggest that you could make a pretty good assessment by the eyeball test, as I call it, looking at differences between the groups and whether you think they're clinically important is probably as good as p-values. And particularly, the sample sizes were quite small, so you'd probably need very large differences between the groups to be statistically significant. So just a small comment, but great presentation.
Thanks so much.
Thank you. We still have a few moments for other questions or comments. Victoria, you mentioned, oh, go ahead, Luxie. And
Sorry.
Luxie, then Michael.
Great presentation, Victoria. I just have a quick question. So I know that foslevodopa-foscarbidopa gets absorbed right into the system, right? But do they control in this study for diet for both of them? Because could that affect potentially the oral medications cohort and what they were taking and how much effect was shown there?
Yeah, they didn't comment on diet. I think the main difference is that if you're directly getting the infusion subcutaneously, then you essentially bypass the effects of protein or dietary effects. But I agree, I guess like those in the control group could be changing their diet on a day-to-day basis and therefore could cause like fluctuations and changes. So that's a really good point, but they didn't at all comment on keeping that controlled as well during the study period.
Okay, awesome. Thank you.
And Michael, you had a question as well.
Yeah, I think it was a very good presentation. And I think like all of us who've seen, early presentations of what seemed to be very promising, the idea that you have something in between oral medication and deep brain stimulation, which is quite an undertaking, and I have a friend on it now and it worked well, is nice because this is really, if you think about what we do with insulin, people on, insulin pumps, this would be a really simple technology and a low-cost technology. So let's hope that it'll come through and we see a benefit, because having it available will have a real impact on people in late-stage Parkinson's. Thanks for the presentation.
Thanks, Dr. Gordon.
Thank you. And Victoria, I agree, your bottom line is very well taken. It seems the discontinuation rate in the foslevodopa-foscarbidopa group was upwards of 30%, as opposed to just under 10% for the levodopa-carbidopa. So, and this is in a trial, so that real world, tolerability will be interesting.
Yeah.
If there are any other questions or comments, we will move on to our second. Oh, there's one in the chat. Thank you for the presentation from Dr. Harriet. Were they infusing the drug before or after meals, as it's affected by amino acids?
Oh, so this was a subcutaneous infusion and it's continuous throughout the 24-hour period. So it was throughout all, I guess like it would have been present during all meals as well.
Thank you. Any further questions or comments, please direct them to the chat. Our second speaker today and future QI master's degree candidate at the University of Toronto, Dr. Rameez Imtiaz, PGY5 Geriatric Medicine subspecialty resident, to present a meta-analysis on acetylcholinesterase inhibitors and a potentially debatable outcome. Rameez,
Thanks.
please share your slides.
Thanks, Dr. Gendel. I'll just share my slides here. And just because I know Eric Wong had just texted me wondering if I'm wearing a tuxedo, this is actually a dress shirt, not a tuxedo. All right, so thanks everyone for joining. I think I've had a chance to work with most people that are on this call, but like Dr. Gendel was saying, my name is Rameez. I'm a fifth-year geriatric medicine fellow, almost done my training. And so for today's journal club, I've elected to present the article Effects of Cholinesterase Inhibitors on Mortality in Patients with Dementia. And to give you a bit of background why I chose this article, I had originally seen this in one of Dr. Gary Nagley's emails. And as someone who does not have any formalized training in critically appraising meta-analyses or systemic reviews, this article was published in a very reputable journal, so the Journal of Neurology, and made some very conclusive conclusions in terms of the impacts that cholinesterase inhibitors can have on mortality in patients with dementia. And it did make me question whether I should be thinking about changing my prescribing practices, particularly in patients that I see who value quantity of life. And a few weeks after that, I received an email from Dr. Gendel Dr. Jennifer Watt and Guy, who's the chief resident at our program, inquiring if I'd be interested in presenting this for Journal Club, because Dr. Watt in particular, who has formal training in this area, identified some concerns on the methodology of this paper. And so the structure of this presentation will be that I will present this paper, and then I will give about 5 minutes or so to Dr. Watt at the end to just really kind of weigh in and speak about kind of what her concerns are with the methodology, and how much value we should give to the conclusions of this paper. So without further ado, we can get started. So I have no conflicts of interest. Just a brief overview. I'll introduce the concept of, I guess, acetylcholinesterase inhibitors, how they came into development. We'll review the journal article, and then we'll go into the critical appraisal and questions at the end. So I don't want to spend too long on this, but just introducing the concept of what is the cholinergic hypothesis. And so the idea behind this is that the neurotransmitter acetylcholine, the first neurotransmitter that was discovered, is plays a very important role in the modulation of cholinergic neurons. And there are two major collections of cholinergic neurons in the brain. The first is the basal nucleus of Maynard, and the second is the dorsolateral pontine. And through multiple different research papers and different analyses, it's been shown now that the cholinergic nervous system is very important in cognitive function, various elements of cognitive function, and this includes things like attention and memory coding. And in patients with Alzheimer's disease, in their postmortem analysis, as well as other sort of analyses, they do have a prominent loss of cholinergic nerves. And so the conclusion that can be drawn then is there a way that we can improve cholinergic activity in the brain? And if we can improve cholinergic activity in the brain, can we reverse some of the changes we see in the cognitive decline? The first acetylcholinesterase inhibitors really were not really discovered with Alzheimer's disease in mind. They were actually discovered in World War II. And so on the left here, you have Richard Chuen, who's a Nobel Prize winner in biochemistry, but he's also a Nazi supporter. And he was given the task in World War II to identifying why sarin gas can kill animals. What is the mechanism behind this? And what he demonstrated was that sarin gas is a very potent inhibitor of an enzyme called acetylcholinesterase. And that enzyme is responsible for degrading acetylcholine and allowing it to be reabsorbed in the presynaptic neuron to modulate cholinergic function. When that enzyme is inhibited, you very quickly get a cholinergic toxidrome, and that toxidrome can have mortality very quickly if it is not well controlled. And hence why sarin gas is sometimes referred to as nerve gas as well. Fast forward from that moment, 50, 60 years in the future, and in today's practice, we have the development of these acetylcholinesterase inhibitor, which are more specific to the central nervous system, and specifically target, again, the same enzyme, which is acetylcholinesterase. Just to explain a little bit of the pathophysiology, so acetylcholine is released from the presynaptic neurons and acts on cholinergic receptors, therefore modulating cholinergic neuron function. And then it is broken down into an acetate and choline group, which can be reabsorbed by the presynaptic neuron. The goal of the acetylcholinesterase inhibitor, like their name implies, is to inhibit this enzyme, therefore increasing the amount of time acetylcholine spends sort of in the synaptic cleft, allowing it to increase its overall function. There are 4 acetylcholinesterase inhibitors that exist. The one that some of the trainees may not know about, certainly I didn't have a lot of knowledge about it, is something called tecarine, which was actually one of the first acetylcholinesterase inhibitors developed, but there are some serious concerns with hepatotoxicity, and hence it is no longer used. And so the ones we're more familiar with are donepezil, glantamine, and rivastigmine. There are many hypotheses about the ways in which acetylcholinesterase inhibitors can modulate mortality in patients with dementia. I would like to share 2 of them here, but just recognizing that beyond this, there are other hypotheses that exist as well. One of the hypotheses is that acetylcholinesterase inhibitors, beyond their sole function of inhibiting acetylcholine, may actually act on other cholinergic nerves in the brain. And this study on the left-hand side was done in rodent models and showed that donepezil and galantamine can directly act on the nicotinic anticholinergic receptor, which again, by virtue of a different mechanism, increases cholinergic activity in the brain, but also may have some anti-apoptotic effect and therefore protect nerve health in patients who have dementia. On the right-hand side is a study that was done in Melbourne, and there's a wide plethora of research on this topic, but the idea that reduced heart rate in itself, even when accounting for other confounding variables, may actually be a predictor of lower all-cause mortality as well as cardiovascular mortality. And so acetylcholinesterase inhibitors, by virtue of their cholinergic side effects, may reduce the heart rate, which in turn may actually be improving the mortality of patients who are on these medications. So let's move on to our journal article. So the main thing that the authors highlighted on this area of research is that most prior studies were either too short or had too few participants to make meaningful conclusions. And therefore, they plan to do a systematic review of randomized and non-randomized control studies to determine the impact of acetylcholinesterase inhibitors on mortality. Their primary endpoint was to assess the effect of long-term treatment, so at least 6 months, with acetylcholinesterase inhibitors on all-cause mortality in patients with dementia. And the secondary endpoint was to look at the impact on cardiovascular mortality. So the one thing that I've really learned from doing this review is that the search strategy is the most important thing when you're designing a systematic review or a meta-analysis. And so the search strategy of this paper was to look at 4 major databases for research articles. So the NIH, PubMed, Cochrane, as well as the WHO International Clinical Trials Registry platform. And within these databases, the included articles had to include either some mention of cholinesterase inhibitor and mention of some type of dementia, so Alzheimer's, Lewy body, dementia in general, etc., and have some mention of clinical trials or randomized controlled trials, cohort studies, etc. In addition to that, all included studies were screened in their reference list for any recent related reviews or guidelines to be included as well. And we will critique, and as well as Dr. Watt will talk about this, some of the challenges with the search strategy for this paper. In addition to meeting the search strategy criteria, included studies also had to meet 4 additional criteria. The first one, that they were a comparative study, either an RCT, either a quasi-randomized controlled trial or non-randomized controlled trial, or a prospective or retrospective parallel cohort study. They had to use an acetylcholinesterase drug and compare it to either placebo or no acetylcholinesterase drug. Included patients had to have dementia, and patients must be followed for a minimum of at least 24 weeks. And the studies had to have reported on either all-cause or cardiovascular mortality. Beyond that, they did use validated tools to look at the risk of bias. So the Cochrane ROB2 for RCTs and Robbins 1 for non-randomized controlled trial. Data on outcome was pooled, and we can talk about some of the challenges when you're pooling data from both RCTs and non-randomized controlled trials together to make conclusions. And there was a sensitivity analysis completed on just RCTs, studies with more than 500 patients, and counting patients that were lost to follow-up as deaths. And there was subgroup analysis also conducted on patients that were younger than 78 compared to older than 79 compared to older than 79 by type of dementia and the type of drug that was used. So let's go through the results. So the first result is really just an overview of their search strategy and the papers that were included. So in the end, there were 24 trials that were included, 12 of which were RCTs and 12 of which were parallel cohort studies. Majority of the studies were on donepezil. This is a table from their supplementary studies or supplementary included paper, and I included this table because one of the conclusions that they make in their abstract, if you read, is that they included studies with lower risk of bias. But when you look at their supplementary studies and you look at kind of the outcome of ROB2 and the Robbins 1 assessment of bias, you'll see that 3 out of the 12 included studies did have some concerns, at least the RCTs had concerns with randomization. And in the non-randomized parallel cohort studies, with the Robbins 1 assessment, 8 of the studies had moderate risk of bias, with 1 having serious risk, particularly when it came to accounting for confounding variables. And so there was some degree of bias kind of included in the studies that were used. Moving forward, when we look at the conclusion, the demographics of the randomized control trial, what we see is that majority of the studies were in patients less than 1,000. So a couple of studies had patients more than 1,000 patients. Majority of the studies were in Alzheimer's disease, with 1 being in Parkinson's disease. And what I thought was interesting is when we look at the MMSE scores of the studies of the RCTs, we'll see that many of the RCTs were really in MMSE scores that we see in more moderate and more severe stages of dementia. Most studies met the threshold criteria for 6 months, with a few of them going over, with 1 being 24 months. In the non-randomized parallel cohort studies, when we look at the demographic data, expectantly, we find that there is a larger cohort of patients that were included, and the follow-up times were significantly longer, with 1 study being up to 10 years for follow-up. When we look at the figures of included studies, so the first figure included here is for all-cause mortality, looking at the crude death rate. For the RCTs, there is a signal towards reduced risk ratio for crude death rate. And the other figure that I pointed out here is the I-squared, which is a measure of heterogeneity. And we'll speak a bit more about heterogeneity and what it means, but you'll see in the RCTs, the studies were quite similar. Heterogeneity was rated as 0%. This is not the case with the non-randomized studies. So even though there was a signal towards reduced crude death rate and all-cause mortality, there is significant heterogeneity in the non-randomized studies. And overall, when we combine the two, there is a signal towards reduced crude death rate with use of acetylcholinesterase inhibitors when compared to placebo. In the multivariate adjusted hazards ratio, one of the randomized controlled trials examined this for all-cause mortality, and there was a signal towards reduced all-cause mortality. And in the non-randomized studies, many of them included a multivariate adjusted hazards ratio. And again, despite significant heterogeneity, there was a signal towards reduced all-cause mortality. When we look at just cardiovascular mortality, and for the next set of figures, you'll see that they have grouped RCTs and non-RCTs together, trying to come to a singular conclusion. For crude death rate, we do see a signal towards reduced cardiovascular mortality. And a couple of the studies also did a multivariate adjusted hazards ratio on cardiovascular mortality, which again had a risk ratio of 0.47, which was statistically significant. In their subgroup analysis, they did look at different cholinesterase inhibitors. Now, the majority of them, the studies included donepezil. And so when we pool the studies together, we do see a signal towards reduced all-cause mortality. A few of the studies had galantamine and rivastigmine, and at least for the galantamine, the signal persisted, but this was not the case for rivastigmine. And if you look at just any acetylcholinesterase inhibitor, i.e. they were not specified what the patients were taking, there was an overall signal towards reduced all-cause mortality. In terms of the type of dementia, this relationship existed for Alzheimer's disease. There was one study on vascular and one study on Parkinson's disease dementia. Both were not statistically significant results. And in terms of studies that did not identify what kind of dementia was included, there was an overall signal towards reduced all-cause mortality as well. In terms of the subgroup analysis, looking at less than 80 and comparing it to 80 years or older, in both populations, there was a statistically significant result. You could argue that the result was stronger in those that were less than 80 compared to older than 80. In terms of the severity of dementia, in the mild and moderate stages, there did seem to be a stronger signal, particularly in the moderate stages where the risk ratio was 0.5 and statistically significant. which was not as significant in the more severe stages. And then finally, they did not show any tables for this, but in their sensitivity analysis, looking at RCTs only, non-randomized studies only, studies including more than 500 patients or counting missing patients as death, overall, there was a signal towards reduced all-cause mortality with the use of acetylcholinesterase inhibitors. They also used a grade system to rate the evidence of the papers that were included. And using the grade system, all 12 sets of RCTs maintained their high-quality evidence rating, and all 11 cohort studies maintain their quality of low-quality evidence rating. So what are the conclusions that they drew from all the tables that I've shared with you? So this is directly from the article itself. So they concluded that there was moderate to high-quality evidence from both randomized and real-life non-randomized studies to suggest that long-term treatment with acetylcholinesterase inhibitors is associated with a reduction in all-cause mortality in patients with Alzheimer's disease, as well as other types of dementia. That evidence does persist for cardiovascular mortality, but possibly a lower quality evidence base. And the accumulated evidence that they found in their paper is solid and should lead us to reassess their use in patients with dementia. In terms of the critical appraisal, there are validated tools to critically appraise systemic reviews. And so the one I used is kind of listed here in this paper. The questions that it asks you to go through, the first question is, what question did the systemic review address, and should be easy to identify what that question is? And I would say in this paper, it was very clear from their intro, the question that they were hoping to answer. And so I answered this as yes, it was easy to identify this question. The second component is it unlikely that important relevant studies were missed? And you know, when you look at their search strategy and you compare kind of with other papers that were done with a similar sort of topic in mind, and again, Dr. Watt can speak a little bit more about this, but they did miss a number of studies specifically looking at the relationship between mortality and acetylcholinesterase inhibitors. And so I wonder if those studies were included, would that have changed the outcomes that they reached in their study? Were the criteria used to select articles appropriate? While I don't think it's necessarily wrong to include RCTs and non-RCTs, I think what I found a bit problematic was that they attempted to combine the two to make conclusions about sort of the various aspects in their paper. And that does introduce significant bias in the results section, and so I elected to answer this as no. Were the included studies sufficiently valid for the type of questions that were asked? While the studies may have been valid, there was significant bias, at least in the non-randomized controlled studies. And overall, there was a tendency towards lower quality of evidence as well in the non-randomized controlled studies. So I elected to answer this as no. And finally, were the results similar from study to study? And this really speaks about the heterogeneity. And while heterogeneity in itself is not necessarily a bad thing, and you would expect in non-randomized control studies, at least, there to be some heterogeneity, I think where it becomes problematic is when you have such heterogeneous studies and you're attempting to answer a singular question, there is that potential that because these studies were very different, you could be missing important confounding variables, which would ultimately change your outcomes. And so I elected to answer this question as no as well. And so I guess, you know, Dr. Watt, I'll let you come on now and maybe just speak about some of the concerns that you found with the methodology of this paper.
Okay, great job, Rameez. That was a really excellent summary of this paper and its methodology and some of the concerns that people should consider when they're reading it. So that was really excellent. I will preface my part of this discussion by saying that while this exact topic, mortality risk from cholinesterase inhibitors in people with dementia, was not the focus of my PhD work, I ended up having to do a fairly deep dive of this area as part of my thesis work, and so I am pretty familiar with this body of literature, at least as it stands like over the last few years, of course. And so having said that, when I read this, I had some concerns, and sort of so much so that after talking with some people, we said, we really should formally write about this. And so we submitted a letter to the editor of Neurology. And of course, as everybody knows, Neurology is actually a very good journal in the neurology literature, and very influential because of its high impact factor, and how far, like how many people read it. And so we just, we were concerned about the study's quality and its potential impact given where it is. And as Rameez, said, on the surface, it can seem like a very good paper, or potentially a good paper. And, the topic's very interesting. And so, this could influence practice. And so we really want to talk about some of the limitations so that we understand whether or not it should be changing our own practices. And so what I'll do is I'm just going to go through some of the points that we raised in our letter to the editor. And this is published online. And actually, we just received a confirmation that it's going to be formally published as the editor's choice for a letter to the editor in Neurology. So it's, I guess, going to be coming out in a formal publication at some point in the future to hopefully sort of get more people talking about some of the potential limitations of this study. So first of all, as Rameez said, there are definitely some shortcomings to the literature search strategy. And when I wrote the letter to the editor and asked for the author's response, I was really trying to get a good sense of how they developed their search. And to be honest, the response wasn't what I was hoping for, unfortunately. Writing literature searches is actually quite a technical skill. It's not just about key terms. There's other things called, subject headings. You have to use different truncations of words, and there's validated filters, and then there's, gray literature. And this topic is actually especially challenging because, in these studies, mortality is actually being reported for the most part in the randomized trials anyway as an adverse event, which means it's not necessarily being reported in the abstract. And so it just makes it more challenging. So, when I read the search, I had concerns, but knowing more about this body of literature as I do, I went back to my data from my thesis, and I found that they actually missed 24 randomized trials that would have met their inclusion criteria. They reported that there were 12 randomized trials that met their inclusion criteria. I found an additional 24, which means they missed 2/3 of studies. So, that's obviously really, really bad for that to have happened. And further, they say they didn't use any kind of language restriction when they were doing their searches, but I know that there were studies published in another language that they should have included that they didn't. So they missed a study published in another language. And so it would be important to understand, how they did their search of other languages. Oh, 1 second. Okay, go with Dada. There we go. Okay. So that's one thing. The second point is around potential protocol deviations that they made. And so in their Prospero registration, which is where we register protocols for systematic reviews, they don't say anything about applying a criteria of studies having to be at least 24 weeks in duration. But that's clearly an exclusion in the paper as published. And this is important because this would have resulted in the exclusion of a further at least nine randomized trials. And I should say my numbers are only current as of 2019. So there may have been further studies published since then, but at least 9. And they had done a couple of other things that I would have wanted them to comment on, or the rationale for why they made these protocol deviations. Maybe there was nothing nefarious about it at all, but they should just comment on that. The third point had to do with their use of something called trial sequential analysis, which isn't necessarily a new concept, but I know a lot of us are not as familiar with it. And it's just sort of a method where, the way we estimate sample sizes that you need in a randomized trial to detect a statistically significant difference or clinically significant difference. You can do the same in a systematic review with meta-analysis. And so that's what they were trying to do here. And you actually make many similar types of assumptions when you're trying to calculate this sample size. The issue was that, they said conclusively for all-cause mortality that, they had met this threshold of the sample size that would be needed. And they used this as a justification for why their results were valid. However, trial sequential analysis is meant to be an assessment of just that, clinical trials, but they actually included also the non-randomized studies in their when they added up all the sample sizes of the studies. And of course, as you know, like some non-randomized studies can be very large. So it could really quickly become very easy to meet that threshold. And that's just not the way these models were developed. This one anyway, that the authors used, there's different ones, was developed for randomized trials alone. And then the fourth point would be that they just put all the data together in one model without considering whether studies were randomized or non-randomized when they pooled their data to derive their effect estimates to say, that cholinesterase inhibitors decrease mortality, when in fact, we know that this is not a recommended approach. There's actually like a group of people who've got together who are, who know a lot about this area. And, there's other methods that have been developed and are recommended, some of which involve Bayesian analyses, which we don't need to go into right now, but all that to say, the way that they modeled their data is not the preferred approach. And so that was unfortunate. And the last point in the letter to the editor, Rameez actually addressed really well. And so we don't need to spend any time talking about that. It was just about how, the abstract didn't necessarily reflect the quality of the studies that were included in the systematic review. And, that could be very, often people just read the abstract. And so it's really important that the abstract reflect the content of the manuscript. And so that's everything. And yeah, so any questions for Rameez, but I'm happy to answer questions as well.
Thank you, Rameez and Jennifer, for that detailed and enlightening insights into the limitations of the paper. I quickly tried to Google your letter to the editor online. I wasn't able to find a link. If there is a link for it, we would appreciate it in the chat box. Karen De Silva has her hand up. Go ahead, Karen.
Thanks so much. And Rameez and both Jen, thank you very much for excellent presentations. And congratulations, Rameez, also because I know this is your busy time preparing for an exam, which is great. I'm just interested, so the issues about methodology are troubling on a number of levels in this impactful journal. But I wonder from, I guess, a conceptual and a theoretical level, Rameez, what do you think about a study about dementia looking at mortality and length of life alone without considering sort of quality of life?
Yeah, I mean, I guess that's maybe getting at a separate sort of argument there. Should we even be valuing quantity of life without having some sort of measure of underlying quality that's present? Ideally, yes, a perfect study would have kind of both components included in its analysis. I think, at least for the purposes of this study, very much it was just to kind of look at, is there any means by which that we're missing that acetylcholinesterase inhibitors could be increasing quantity of life? And really the purpose, I guess, of this study was really not as much quality, but I certainly agree that, and most of us would, I think, agree that in dementia, which thus far is a debilitating condition over time, quality has to be some metric that's included in a more ideal, a more holistic look at this topic. I hope I answered that question in terms of what you were looking for.
Thank you. And Michael, your hand is up. Go ahead.
Yeah, very good presentation. I was very interested in this. I think one of the problems I see is that we prescribe these drugs basically to improve symptoms. And we know that there's some controversy, but I think most of us in practice say, at least in a proportion of patients, there's an improvement in symptoms for a period of time. I've had some for many years. To me, the reason this is a useful study is that even if all the methodologies were not perfect, the benefits are all on the left side. I would be worried about a drug that increased mortality, because when you are speaking to patients, they say, are there any terrible, we talk about side effects, but is this drug going to do something bad to my mother, separate from, nausea, whatever? Increased mortality is a real thing. We lost the whole hormone replacement therapy. It was in the New York Times, if you saw it, that wonderful article about menopause, because of an increase in mortality in a small proportion of patients. I would be concerned if there was an increase in mortality. Even if it were neutral, if it showed no change in mortality, that would be good, because patients come and they say, I'm afraid to take the drug because, and then one could say, well, there's no evidence of the bad because, and maybe better study benefit in terms of mortality. That's like a cream on the top of a cake. Sorry, thank you.
Thank you for those comments. The chat box has lit up somewhat. Shabir Alibi, great presentation, very good critical appraisal. The study results are frankly difficult to believe. I will also add that I think there were 3 Cochrane systematic review meta-analyses of each acetylcholinesterase inhibitor individually. Rameez, Jen, you can correct me if I'm wrong, but those 3 systematic reviews meta-analyses did not find this mortality benefit, and perhaps their methods were more robust. Thank you, Jennifer, for including the link to your editorial. Ariel Berger writes, if they found the same result with sensitivity analysis, dividing the randomized and non-randomized, wouldn't that support their conclusion rather than being a limitation? And Shabir says, yes, but if they exclude a bunch of studies and miss a bunch of studies, hard to believe their findings. Plus, not all studies report mortality outcomes in a way to allow data to be fully included. So there you have it. Karen, is that a new question, De Silva, or is that your hand from earlier?
No, sorry, old hand.
I see. We still have a minute or two for a last question or comment.
I just want to, so I guess the consensus, it seems like, is we are not going to believe this study and we are not going to prescribe this drug to prolong mortality. That's the sense that I'm getting.
Thank you, Rameez. The bottom line from the presenter is not to counsel patients or advise that this medication can extend life. And a last comment from Ariel, I worry that we are too influenced by ageism and implicit bias against disability, that we are willing to ignore any signal that it might be helpful. So thank you for that perspective. So with that, I will bring February Journal Club to a close. Thank you very much to both of our presenters, Victoria and Rameez, for beautiful presentations. And Jennifer, thank you very much for your time and oversight to help enrich our understanding of the methods in systematic review. Very, very enriching discussion this morning. Please remember to complete your evaluations. The link was recently sent, and we will see everyone next month. Thank you, everyone.